Let's go ahead and get started. Good morning, everyone. Happy Wednesday. Welcome to the May Cost Growth Target Technical Advisory Group meeting. We are going to start, just real quick, start with some housekeeping. On the next slide, please. We are recording this meeting and it will be posted to the webpage. And it's really helpful for us in facilitating the discussion if you can rename yourself so we see your name and your organization. Thanks. All right, so next slide. For today's agenda, I'm going to do a roll call and we'll see who all is participating. We'll talk a little bit about the April 28th meeting summary. We're going to spend the bulk of our conversation today on the data submission template and specifications. We have a number of specific questions to work through with you all today. And then at the end, we have a couple of other implementation updates to share. So let's start right off with roll call. I'm going to go down the list of payers on the left of the screen, and then we'll capture other participants after that. So do we have anybody from Advanced Health today?
Hi, everyone. This is Chris Hogan at Advanced Health.
Hey, Chris. Okay, All Care. Anthem. Atrio. Care Oregon.
Hi, Terry Heading from Care Oregon.
Hey, Terry. Cascade Health Alliance. Cigna.
Hi, Jason Loftus from Cigna.
Hey, Jason. All right, Companion. CVS Aetna.
Hi, Tracy Cole is here.
Tracy.
Hi, Alicia DeJesus is here.
Hey, Alicia. First Health. Healthcare Service Corps. Health Share. Humana.
Cal Maloney's here.
Hi, Raquel. Kaiser.
This is Keith Cronin at Kaiser.
Hi, Keith. Moda.
Yeah, Bill Dwyer here.
Hi, Bill. Anyone for Medicaid fee for service? Pacific Source.
Hi, this is Jeanette Sims, and I have Kyle Harada and Clara Combs from Pacific Source here.
Great. Hello, welcome. Providence.
This is Kristen Downey. I think Drew Tarab is also on, and Jackie Fabric.
Great. Welcome, everyone.
Sorry, I thought I was off. Yes, Drew Tarab.
Hi, Drew. Okay, Regents, Cambia.
Hi, this is Jared Collins. I'm here.
Hey, Jared. All right, Samaritan.
Hi, Trent Began, and it looks like Wade Penner is on as well.
Great. Welcome. Trillium HealthNet.
Julianne Duncan is on the phone.
Hey, Julianne, welcome. Sorry, trying to type at the same time. Umpqua.
Hi, this is Jameson Baird with Umpqua.
And Keith Lowther's here too.
Great, Keith and Jameson, thank you. All right, and United.
Hi, good morning. This is Anna Morales from United.
Hi, Anna. Looks like I also see Peter on the line. Hey, Peter.
Hi, Peter Hindle, United.
All right, and Yamhill.
Good morning, Larry Soderberg.
Hi, Larry. Okay, did I miss any payer participants? Okay, do we have any provider participants today?
All right, not a specific provider, but this is Jeff Winkley from OAHHS.
Hey, Jeff, welcome. right. Do we have any folks from DCBS on today?
Yes, Gail Woods is here.
Hi, Gail. Welcome. All right. And other non-OHA participants?
This is Richard Gibson from Comagine Help.
Hey, Richard. All right. And on the staff and consultant side, this is Sarah. We've got Megan Burns from Baylet Health. And I know we have a number of other team members on. OHA folks do, let's see, we've got Zachary, Ishan, Liz, Sam. Did I miss any of you? Ben, hi Ben.
Trang.
Sorry, Trang.
That's fine.
All right, I think that's everyone. So full crowd today. Thanks everyone for joining. Glad you are all here. Let us go ahead and dive into the April meeting summary. So on the next slide, I'm just going to recap some of the decisions that were made, hopefully which all will sound familiar to you if you were listening to the discussion. So first off, short-term health plans will be included, but that appears moot for Oregon. We don't appear to have any short-term health plans that meet the threshold for inclusion. So if that changes in the future, we will include, but probably not relevant at this point. We are not going to require IBNR for claims, but we are going to require at least 180 days claims run out. Providers have shared, or payers have shared that the data are very complete at 180 days, and we're feeling comfortable with that. The initial data submission, which will cover calendar years 2018, 19, and 20 data, is due on October 1st, 2021. All payers who are mandatory reporters for this cycle should have received an email that came from Trang with that mandatory reporter notification on Monday. So we'll talk more about that later, but that has gone out and the official due date is October 1st. We talked about whether or not we should have a separate reporting process for the non-claims data and agreed that we would not do that. We'll have one data submission date, which will include the claims and the non-claims data. We also talked about the categories for reporting non-claims data, and we'll be using the Millbank categories, and those will all be included in the updated specifications. So exactly what's in those specific categories for non-claims data. And then we talked about the other line of business option that Massachusetts is using for some specific purposes, and we agreed that we did not have any use case for that and would be removing it from the Oregon data submission template. We also, sorry I didn't put this on the slide, but we also talked about adding a behavioral health provider category, and there was agreement that we should do that, behavioral health provider claims or behavioral health provider service category. Any questions or comments about the April meeting summary? Okay, was there anyone who was attending last month that was not listed in the participants? Did we miss any attendees? Okay, great. So let's go into the data submission template and guidance document. So on the next slide, please. Thanks, Michelle. We're going to break this conversation out into a number of questions, and we're going to go through these in this order. And then after these questions, we'll have time for other questions that you want to bring up related to the data submission template and specifications. So the things we want to cover today, what spending are we trying to capture? We just want to provide a little bit more grounding and confirm some of those details. We want to have a pretty detailed conversation about how to handle vendor and carved out services. We had a question last month about how to handle pharmacy rebates that are passed on to employer groups that we want to revisit today. We also want to talk about whether to collect standard deviation or variance to support the statistical testing for accountability. And then we want to start a conversation about risk adjustment. So I don't know that we're going to land it today, but we wanted to introduce it and start getting you thinking about this. Okay, so I'm just going to keep talking into this first section about what spending we are trying to capture. So we mostly wanted to just reground in what we are trying to capture in this data submission. We've talked about a lot of different kinds of payments, whether that's outgoing payments to providers or other entities, as well as incoming payments or settlements that payers are collecting. We really wanted to just focus in on what we're trying to capture with the Cost Growth Target Program. So on the next slide, please. We are measuring both total healthcare expenditures and total medical expenditures. These 4 buckets are the definitions that the implementation committee agreed on and worked with, and this is how we are organizing all of the content. So we have in the red box on the left, all of the claims-based payments. In the orange box, we have all of the non-claims-based payments. The green box, we have all of the member cost sharing. And then in the blue box, we have the net cost of private health insurance. So as we're thinking about this, we're measuring both the total healthcare expenditures, which are all 4 of those at the highest level, at the state and the market level. And then we'll be measuring the total medical expenditures at the payer and provider level. So next. So for the purposes of what we're trying to capture in the data submission template, we are really trying to measure total medical expenditures through the lens of payer to provider payments. So there are a lot of other dollars that are out there, but what we're really trying to capture is those payer to provider payments. So next, I think one of the questions that has come up and one of the concerns that has come up is this really capturing all healthcare spending? And we just wanted to reflect that no, total medical expenditure will not capture every single dollar, and that there's some noise in this. So sometimes dollars will be miscategorized as either payer revenue or provider revenue in both directions. And that's okay. We're not going to get that 100% clean every single time. But as long as payers are consistently following the specifications, there's some shared understanding of what's being captured where, that trend will be consistent over time. And since what we're really looking at is the trend, we are okay with that. So again, just reflecting that this is not every single dollar, and that it's not going to be 100% clean, but that is what we are focusing on. And we thought it would also be helpful to go back and share a slide that we used with the implementation committee last year. And we've been calling this our triangle slide. So on the next slide, this is really showing again, a very crude reflection of the dollars flowing across the system. So starting in the top left of this slide, we have revenue, so dollars that are coming into payers, whether that's premium collection, whether that's CCO capitation rates, whether that's other settlements, anything coming in as revenue is being ingested into the payer. We then have the dollars that are flowing to providers, whether those are direct to providers or if they're going through vendors or subcapitated arrangements. That's the horizontal line straight across the bottom. And then we have the patient perspective. So we've got members paying their premiums to the plan on the left side, and we've got member cost sharing to the providers on the right side. So next slide just shows the highlights of what we're actually capturing in the total healthcare expenditure and the total medical expenditure highlighted in the yellow boxes. So again, we're looking at those payments to providers across the bottom. We're looking at the patient cost sharing in the right side of the triangle. And again, the bottom left is the net cost of private health insurance, or those admin costs. We're really not trying to include any of the revenue, whether that's the premiums, the capitation, or anything like that. So let me stop talking there for a second. Are there any questions about this framing or what we're trying to include? Megan, did I miss any of the key points that we wanted to cover here?
Nope, I think you hit them perfectly, Sarah.
Thanks. Any questions? Then let me just cover a few more pieces of this. So on the next slide, just to summarize the net cost of private health insurance, the intent of this category is capturing the administrative costs. It is calculated essentially as premiums minus claims as reported on financial reporting forms. and we'll be using, and in those forms, the claims payments include some non-claims payments according to NEIC rules. So again, there's some noise here between how we're talking about things in the payer submission and how things are captured on the NAIC side. But again, going back to that triangle side of what's included, and the net cost of private health insurance is included in the total expenditures, but we're not trying to capture that in the payer data submission file itself. Did I say that correctly?
So there are components of the net cost of private health insurance that you'll want to specifically collect, and that is fees related to the income for self-insured plans. I think I said that there's a financial term that I think I just bungled up, but it essentially is it's the revenue into the payer for the self-funded business. And that information has not consistently come through on the NAIC forms.
And that only applies for self-insured plans. So it's not a broad piece of information that's being collected from every payer.
Every payer that has a self-insured business, correct.
Okay, so let's go to the next slide where
Sarah,
we wanted to start. Oh, go ahead,
Can I
Jared.
ask a question on the prior slide? This is Jared from
Please.
Regions. Are there expectations that the submissions will tie out in some way to the financial reports and things that are required, or are you just using similar definitions?
Do you mean the TME data? Sorry, Sarah.
For the other slide, for the net cost of private health insurance, you got your line or NCPHI equals premium minus claims as recorded on financial reporting forms. So just wondering if there's going to be some tie out or checks to those financial reports.
I'm not sure what exactly you're asking. I think we're saying that we are going to be pulling the NAIC files down, using that as one of the data sources for this. But in terms of truing it up or auditing, I don't think we're trying to reconcile that. It's just another one of the inputs. Megan.
That's what I was trying to ask, if there were any sort of, we report on these submissions and then there's the form submitted to the NIC, just wondering if there's any validation between the two. It sounds like no.
So I think it's worth, so to calculate the net cost of private health insurance, the data that are in the NAIC forms are the data that are used. To look at the TME data that comes in, absolutely, there is a look at those NAIC forms, but there in no way is a tie out, and we understand that, and that's because of the timing in which those NAIC forms are filled out and a whole other sorts of accounting reasons. But it's certainly, there should be sort of general ballpark over time sorts of things. If we see something that's completely wacky, I think Sarah and her team will call you up and say, hey, can you help us understand this? But it's not meant to be some sort of tie out. We get the limitations on these forms. Does that help, Jared?
Yeah, thank you.
Yeah.
Thanks. Okay, so let's go to the next slide. And this is our attempt to capture and maybe put a starting place in the ground for conversation about how certain payment types, whether that's payments out to providers or revenue coming into payers, should be included or excluded in the reporting. So again, we're focusing on payments from payers to providers. So we think that means that the following should be excluded because they count as revenue. And I'm going to just keep saying revenue, even though I recognize that revenue is maybe not the most accurate term for everything that's captured in here. So some of these things to be excluded would be statewide reinsurance program for the individual market, Medicare sweeps payment, other reinsurance recoveries, and premiums that are collected. However, if any of those dollars are then distributed or paid out to providers, they would be included in the submission and they would be reported as either claims or non-claims based payments to providers. So quality payments to providers, shared savings arrangements with providers, and then reinsurance or other payments that are distributed to providers. So this is where it starts getting a little messy. So we're going to talk about Part D settlements on the next slide separately, but wanted to pause here and see, are there other payments that are in question? Does this exclusion inclusion split make sense to you? What do you think?
Hey, Sarah, this is Drew from Providence. I can't recall if we also talked about ACA risk transfer payments as being included or excluded. They have a similar-ish feel to Medicare sweep payments in that they reflect relative risk. In Oregon, the payments can be pretty significant, and they do reflect morbidity of a population.
But those dollars come to the payer, right? They're not being distributed out to the provider as their own sort of pass-through payment.
Well, I mean, there's a yes and no, not to, divulge too much proprietary info, but if you had a risk arrangement with a provider that was medical loss ratio based, that risk arrangement would be net of any risk transfer payments, which would apply in Medicare as well as ACA or any other sort of risk arrangement that was medical loss ratio based.
But you'd be capturing all of those risk arrangements, risk payments to the provider in your non-claims based reporting categories.
Yes, that's accurate. Yes.
So I would say that then the ACA risk transfer payments would be in the exclusion bucket because we don't want to double count the incoming dollars.
Okay.
Does that make sense? Okay. Other questions about this? Are there other specific payments or settlements or things that we didn't list here that we should also talk through? You're quiet today and it's making me a little nervous. So please, please ask your questions if you have them. Okay, if not, let's talk about Part D. So we wanted to talk about this one a little bit separately because there's some more nuance. So we know that Part D settlements can be significant. They can take years to close out, and that causes some timing issues. And there's some differences in how these settlements show up. So that was really high level, but I want to jump right to our proposed approach. So if at the end of the day, the Part D settlements are being booked as medical costs, then it should be reported as TME and we'd want to include it. And it should be spread across the membership proportionately. If it's not being booked as a claims cost or a medical cost, then it should be excluded and we don't want to get further into the weeds of those settlement payments. What do you all think about that proposed approach?
I think it adds a lot of complexity. This is Drew again. It definitely adds a level of complexity. The Part D settlement does include, in essence, like a contra claim. I mean, it is a true up. It's both revenue and claims in the Part D settlement. There's several parts.
Yeah.
And for spreading that out across membership proportionally, certainly not an easy task. I'm trying to get my head around like what's the risk of just excluding Part D settlements? Like what do we leave out? And I worry that you leave out a lot, but it's also really hard to spread it.
So it feels like there are two potential, I guess, branches in this conversation. One is including if it shows up as medical and excluding otherwise. And then is it spread across membership proportionately or is it handled somehow differently? It sounds like, Drew, your concern is with the spreading it out and less about the what parts of it get pulled through.
Yeah, I think that's accurate, Sarah. The part, I mean, the Part D settlement is in fact, but there's components to it, and one component is in fact a claim cost, a pharmacy claim cost.
Yeah. Dean, you've got your hand up.
Yeah, so in Part D, there is you haven't kind of mentioned the revenue side of Part D, but the vast majority of Part D is an estimated payment, a significant estimated payment compared to various buckets of cost. And for NAIC statutory accounting, it's not recorded as revenue, but the plans are obviously getting it. And then the expense isn't really recorded as an expense. The only thing that's recorded potentially as an expense is the risk corridor portion of it that is due back and forth from CMS and back, and could go both ways. So it could be a medical cost, or it could be a surplus or a reduction in cost, I guess. So I have no idea how, I don't know that this answers the question on how it would be reported.
So I think the proposed approach was meant to be flexible with payer practices. We spoke with an actuary who has looked at data like this and has seen all of the different options that are available out there for payers to record this information, in particular when it comes years later. And so this is really meant to be flexible in accordance with how payers handle this from an accounting perspective.
Well, it's 11 months after the year is when it's reconciled. I don't know that it's an option on how to record Part D funding and Part D expense. There's guidance from NAIC on it, so I don't know how it's optional or flexible for it to be reported on the NAIC forms anyway.
And I think this is where we're not, we definitely are not trying to capture things the same way NAIC does. We know that that's just not possible with this. So I think.
So my comment is this doesn't answer really anything.
Okay. Megan, we talked before about why we don't want to try to exclude this entirely, right? Why that's a bad idea?
I think the reason why we heard from this group not to exclude it is because it can be pretty significant. And so we wanted to find a way to include it as part of that feedback. And Dean, you could be right. What I had heard from an actuary that's looked at this data is that it gets booked differently by different payers. Maybe they're not all following the NAIC guidelines. I'm not sure, but we wanted it to be flexible so that we recognize that these are happening, and that if you are passing them on to the providers, in particular where they're taking on risk on pharmacy spend, we want to be able to capture that. So Sarah, without further research onto the NAIC guidelines, I don't know if we can offer more specific information here.
Yeah, I think we should take this back and do a little more digging. I think if folks have proposed solutions, alternate proposed approaches, we would welcome those ideas. So feel free to just send me an email with any thoughts on this, and we will come back to this.
So you want the actual pharmacy claims submitted, correct? For a Medicare Advantage plan that has Part D.
So we want
the aggregate.
We want the aggregate spending.
So not the individual claims.
Correct. No individual claim submission in any of this. It's all aggregate reporting.
Yeah, so I would just ask you to break down is reinsurance, is licks, is the rebates, are the risk corridors. What is it that you want reported? and if it's funding that it was not enough, or there was so there's money going back to the plan for the reinsurance section of it, or the LIC section of it, or the risk corridor. How is that reported? At each one of those. On the revenue side, when you get a Part D premium, it's recorded as unearned revenue or prepaid or something of that nature. It doesn't typically hit the income statement until the reconciliation. At year end, you're doing a big estimate generally.
I think we also want to keep that focus, though, of that lens that we're looking at, which is the dollars that you are paying to providers for Part D, and inclusive of any of the risk arrangements that they may have.
Yeah, and I think just like we're not trying to fully reconcile, have identical reporting to NAIC, that we are also not trying to fully replicate payers' internal accounting. This is not trying to fully reflect the balance sheet. Again, this is reflecting the dollars that are going out the door to providers. And I do think we can come back to this and provide a little more clarity on what it should be net of, for example.
So if a Medicare Advantage plan has no risk with any part of Part D with a provider network, there's nothing required to be submitted.
Is no risk the same as not paying for it, not covering any of those services?
No risk sharing with the provider network. There is definitely risk sharing between the plan and CMS, but there's no payments of risk corridor, or that would be the only thing that you would share with providers.
So in that case,
would be the only thing.
In that case, wouldn't that just show up as your pharmacy spending?
Well, not necessarily. The risk corridor could be a payment back to CMS, and if that's the case, then you've been paid too much ahead of time.
We're not trying to capture any of the dollars between payers and CMS. We're not trying to look into any of that back and forth.
I think the confusion.
So that's what my question was, is if you don't have a risk arrangement with providers for any portion of Part D, we just exclude the whole thing.
No, we want aggregate claim spending for for the drugs that you're covering. And so I think by saying the lens of focus was payment from payers to providers, lumped in providers being that pharmacies, for example, retail pharmacies or the medical pharmacy costs. So that's what we're referring to.
So nothing, you don't want any, you want the claims expense.
Yes.
The actual, not the expense, the actual claim value, because it's not really an expense.
Right, yes, the allowed amount of the claim.
That the plan pays, or the PBM pays on behalf of the Medicare Advantage member.
Yes.
And nothing on the revenue side.
Yes.
Okay. None of the back and forth.
So, this is Drew. I think we might have diverging conceptions here, because if a Part D carrier is in a situation where CMS owes them money, it seems like it's in the carrier's best interest to show that contra claim expense. It's not, NAIC doesn't, for that portion of the Part D settlement, it is benefit expense. And I think the carrier would want to show that as a reduction in claims expense, even if it's not shared back with any provider. And does that make sense? Because you are reporting out carrier trend also.
So you're saying report it net of settlement?
Yeah, something like that, Megan. I mean, it'd be nice to maybe categorize it specifically so you can isolate it if necessary, but.
Yep.
Yeah, the vast majority of Part D revenue money coming from CMS to the plans isn't revenue. It's an estimate for an expense. The reinsurance, it's just a true up. Did we pay you enough to cover the claims expense or ahead of time in the capitation or not? And if you didn't, CMS owes you some money. If you did, you owe CMS some money. So it's not revenue. It's a true up. It's
I
just
think that's a true
pass-through.
for revenue.
So
Then I
this,
think there's a component that is,
It's a balance sheet issue. It's not an income statement issue.
and that's what I meant when I said earlier that I'm using revenue very loosely. I think it's everything in that top left corner, which does include balance sheet, not just everything that counts as income. So I think for our thinking coming into this conversation was that anything that is a true up back and forth between CMS is all in that revenue corner of back and forth, because it's still related to money coming in and out of the payer, but not the money going out the door to the provider.
It's not revenue. It's a balance sheet thing. It's a prepayment, and then if more money is owed, it's a receivable. It's not an expense. It's not it's not revenue.
Let me just weigh in here a bit. This is Bill from MODA, and I've been listening to this, and also just since I had some time, I've been reading a little bit about these settlements, and I just it doesn't appear to me that we should be capturing any of this in what we're trying to do. I mean, none of this seems like claim costs or some
Agree.
providers, and this whole thing, this whole discussion seems to me just the conclusion should be that we should not be including any of these settlements. That's my opinion after reviewing some of this and hearing the points of view. But I think that you're on the right track there to suggest that maybe we just or you guys just go back and look into this a little bit more. But I think that's probably the conclusion you're going to come to.
Thanks, Bill. So it sounds, I mean, again, I want to recognize that there were concerns about not including these dollars last time. I think given that it is this balance sheet issue, Bill, what you're saying makes sense. Is it just cleaner to exclude this concept entirely because it's between the payer and CMS? Are there other concerns about just excluding entirely?
And can I ask, for those payers that have participated in other states, if you know or are willing, can you share what you've done in other states? There has not been good guidance, I will say, on this particular issue. And so if you're able to share, that'd be great.
Hi, Megan. This is Tracy Cole from CVS Health. I have not ever heard this even come up with the other states. This is something, the reinsurance and the settlements is something totally new to me.
Okay, thanks, Tracy.
Yep.
Sorry to chime in. This is Vince Porter at Cambia. I think the reason why reinsurance hasn't come up is I think we're one of the few states. I doubt any of the others that have these programs have the reinsurance program like this, correct?
This is a little different than reinsurance in the classic sense of reinsurance. There's a Part D payments come in as reinsurance, the amounts over a certain amount. So it's really a reconciliation between CMS and the plan. So it's not reinsurance in the classic sense.
Got it. Sorry.
I think we need to do some more reading. Bill, if you've got suggested reading for us, would love to see that. We will do some digging and come back to this. I think we maybe are more open to excluding. I'm not hearing any firm objections to not excluding today. So we'll do some more digging and come back. But let's keep moving. This was good feedback. Thank you, everyone. Okay. Thank you. One more. All right, Megan.
Great. Okay. So we had a couple of conversations during our last meeting about what to do about carve-out services and vendor services. And I think we struggled a little bit on the language about what exactly a vendor is and a carve-out service. And so we're going to put a little bit of context to this and then ask for your feedback. Michelle, would you please advance the slide? So, oops, sorry about that. I've got multiple screens here. So what we're talking about here is that there are some payers carve out covered services, right? So pharmacy can be carved out from a benefit and is contracted by, to a vendor to provide that benefit and pay those claims. Behavioral health can be, in one state, one payer had transplant services carved out. So there's all sorts of things. And some payers are not able to separately capture the administrative costs of those carve-out vendors or have access to the claims or encounter data for those services to be able to estimate those dollars. And OHA and the other states are not going around and trying to chase all of those carve-out vendors to then pull in the data. So there is a need to do some estimating of this in order to have sort of a complete picture of the population whose benefits have been carved out. So there's a couple of questions that we have. One is, which vendor or carved out services should be included in TME, how to handle those admin fees, how to allocate or make estimates when you don't know how much has been paid to providers so that we can get that full perspective. And then specifically related to how to handle behavioral health carve-outs. So we also just want to recognize that there's variation across the payers and there's even variation across contracts, and that is expected. And so hopefully today's conversation will just provide a little bit more clarity around that and allow OHA to put some guidance into the specifications on how to handle these situations. So, the other perspective here is some of this is going to be guidance, and some of this recognizing that OHA is asking you to participate in this process and to provide data. And there, I think Sarah would agree that there is a general sense of trying to understand that there is a lift here for you, but we want to make this as simple as possible. Okay. Next slide, Michelle, please. Okay, so when we're talking about which vendor and which carved out services should be included in TME calculations, our proposed approach is that any covered benefit should be included in the TME calculation, regardless of how you deliver those benefits, which I think is sort of standard, right? If you cover it, it should be included. But the way those dollars are included in the TME calculations and allocated might differ by how they're carved out specifically. We want to make it clear that vendors or contracts that you have that are purely admin functions, or you've completely delegated an authority, for example, to a provider, those should not be included in the TME calculation. I've got a couple of examples here that we can go through. So next slide, Michelle. So here, let's just say that you carve out behavioral health. It is a covered service, but you carve it out. There's a couple of ways that we have sort of identified that we want to provide as an example. The first is, right, you pay the claims to a behavioral health provider, right? You're going to include that. You might contract directly with a mental health provider, and you might have them on a capitated arrangement. It could be full, it could be partial, it could be value-based payment. We want that included. A payer contracts with a mental health organization to provide services, and then that mental health organization contracts and pays the providers. This would sort of be that carve out option. We want that included. Now, we'll talk a little bit about access to the data for the actual dollars in a minute. But then finally, also, if a payer is contracting with a vendor to provide, telehealth counseling or some sort of app, so long as there are claims associated with that, we want that information. If you're strictly contracting with a vendor to process claims, that is not to be included in TME, that gets captured in the net cost of private health insurance as an admin expense. Our second example on the next slide, please, Michelle, is care management services. And so I want to pause and think about this specifically too. And in particular, which scenarios should be included in the TME calculation. So our thinking is, if you're paying claims for care management services to the provider to do something specific like diabetes care coordination, and it shows up as a PMPM, we want that included. Similarly, if you're offering some sort of program specifically for a population, for a provider to provide that care management, we want that included. If you are contracting with a vendor for some sort of admin support in delivering care management services, that's an admin expense. So again, in all of these situations, the lens of focus here is dollars that payers are paying to providers, even if there's a middleman, for lack of a better term, included in there. Next slide, please, Michelle.
Hey, can we go back to the care management example? Because it's sort of, the first one and the last one seem, similar-ish. Maybe the more direct question is, where would something like PCPCH or CPC plus payments fall?
Those go into, yeah, those are payments directly to a provider to do things for a specific term. Those would go into the non-claims based payment buckets. And we have, I think this group agreed to use the standard approach that the Milbank program, or excuse me, the Milbank Memorial Fund has proposed. And those payments would go into one of those non-claims categories. They'll have specific definition of where it would go.
Thank you.
Dean? Dean, do you have a question? Are you on mute?
I'm sorry, I was on mute, double muted. Could you go back one slide to the third one down? So payer contracts with a mental health organization to provide services, and the MHO contracts and pays that provider. So in an example, in a real life example, a capitation is paid to an MHO. The MHO has staff model providers and they have contracted providers. Say we provide $100 in capitation and the MHO provides $50 in service that's capitated and $40 to actually paying a provider out of that $100. Which one of those is included? Is the $100 or is it $40 or is it $90?
So we think that is going to vary by access to data. You might not
let's
know,
say we have the data. We have the data.
If you have, well, so then let's go on to that question. So you've begun answering the questions that I'm about to ask. So can we advance to slide 23, Michelle? And then we can talk about that specifically. I think it's 23, right? Yeah. So what do you do for the admin costs? And I think part of Dean's question is about those admin costs. What we're proposing is that if the admin cost is separately identifiable, you should not include those dollars in TME, right? So Dean, in your case, you're paying, I forget the exact numbers, but you understood how much was actually going to the provider and you understood the differential between what was going to the provider and what was going to the organization. I would call that differential the admin costs. Okay,
so the capitation in general is, from the plan's perspective, is the total cost, is a medical expense.
Understood.
Then what the vendor does with it, so half of that money is in an encounter that it's capitated, and then a portion of that is paid out to an actual provider that isn't capitated. And so that some amount, say it's $100 in capitation, or $100 the plan pays in capitation, not including admin from its perspective, and then the vendor uses $90 of that for actual services.
So in the real world, do you actually know that information? Or do you
Yeah,
just look
we
at that
do.
$100?
On this particular situation, we do, because we require encounter data that's capitated, and we also pay their claims to their non-capitated providers, but they are fully at risk for it. So, yeah.
I think what we're proposing here is basically, if you know what that admin is, don't include it in TME. If you don't know what it is, it's okay to include it. And we have a couple of approaches on how to do that.
So
And
just
so our perspective, the $100, the plan's perspective is the $100 is the expense, not the 90 in my example, or not the 50 that actually goes to a provider.
In your example, Dean, I would say you should be including the $90 because all of those $90 are paid for services.
Okay, then what happens? Then use the other scenario. We give them $100, but they spend 110. Then which one?
It's if you don't know what that admin is and they exceeded their cap, no one is paying for that, right?
Well, yeah, certainly somebody is. They are as a vendor.
Yeah.
And the providers get that money, right? The providers.
I'm sorry, I didn't. Right. I don't mean from a TME perspective. Again, that lens of focus is the payer dollars going out to the provider. In this case, it's going out to the vendor. And what I think we're trying to separate out is if you know the admin costs and that's something that you have access to, exclude it from TME. If you don't have access to it, we're going to make a recommendation on how to spread that around.
Yeah, so in this scenario, the plan's perspective is the cost is $100. And in either scenario, that's the plan. We have a portion in the contract that is specific for admin above the $100 that we're not including in this. It's they're taking the risk for so that's the plan's perspective. But
the implementation
to me that would be that would be the way that you would want it reported.
Yeah, and the implementation committee made a decision and recognized there were providers that were participating in that. They recognized there are costs that the providers bear that aren't going to be captured, and it comes out of their overall revenue. It could be because they lost on a contract in this case. It could be because there's concerns about the population of individuals who are uninsured and are seeking care, and charity care programs and bad debt and things like that. But the implementation committee's lens of focus again is that dollars to the provider or the vendor. I don't think that
which is the 100 that went to the MHO.
So Dean, I'm sorry, I just want to clarify. Are you saying that from your perspective, you actually are paying them $102 and 100 of that is medical and the 2 is the admin?
Yeah, well, in certain contracts, you can call out specifically what you're paying in admin, which I would say definitely you would exclude.
Yes.
In capitation arrangements that do not, and that the plan indicates it's a medical expense, I think the best approach is that is the expense, not what's downstream, what a fee-for-service provider got, or a value of a capitated service. I think you're just running into a slippery slope, and you're not giving. You're hurting the plan. If the goal is to somehow determine is the plan hoarding money or something, or what their rate of growth is, it just doesn't seem logical to me to go further downstream than what the plan's expense is. Because that you're paying the provider one way or another. A provider organization is getting that money.
We just don't want to double count the dollars, Dean. We just want to make sure that
and you
those
wouldn't
admin...
be if right. Yeah, and so again, I think that's dependent upon each organization's contracts with a downstream vendor. Does it call out admin or does it not?
Exactly.
And if it doesn't, then you include it. And if it does, you exclude the admin.
That is exactly what we're proposing. Sorry, and Drew has his hand up too.
Thanks, Sarah. I'd like to be able to articulate back what Dean said so I make sure I understand it also. And I'm going to use a slightly different example. Carrier X pays a vendor, let's call it like a vendor like Optum, $50 per member per month to manage our behavioral health services. And then Optum goes and makes payments to providers throughout the state of Oregon for Carrier X's members for behavioral health services delivered. Is the carrier to report the per capita, the $50 PMPM, kind of peanut buttered across all our members? Or are we to look into all the, that's what I think Dean and we all just agree, or at least you two agreed, that's what we would do. But it didn't, that if the capitation payment that was made, assuming we can carve out the admin component, would be what we'd report, and it would be peanut buttered across our membership. Is that accurate?
So the behavioral health one, I just want to put a pin in, and so let's just call it a different service, okay? Because I think behavioral health is going to get confusing, and I want to talk about that a little bit later.
Sure. So we pay Optum to manage lab services, $10 per month. We can back out the admin component, so it's $9 in cost, and well, benefit expense cost, and then Optum may have to spend $100 because they got hit with some really super expensive drug. We're going to be blind to that in this reporting. Is that accurate?
Right.
It's just the dollars out, the checks that the health plan had to write.
That's right. And it would show up as the PMPM payment. And I love the new term that I learned from you this week, which is peanut butter it across the population that you're reporting on, specifically for those members whose benefit has been carved out. Yep, it's not perfect.
Thanks, Megan.
Mm-hmm.
So does the next slide gets more into the peanut buttering, right?
Yes, so let's move on to the next slide. Okay, I'm just trying to, Michelle, I think we want to go one back. Is that right? Or is this, I might be looking at old version, right? Nope, here we are. Okay. Sorry, go ahead. You were right, Michelle, go ahead. Go ahead forward. And I would love to hear the perspective of Tracy, if you're willing to speak up again, or United or Cigna here, since each of these organizations have done this before. Ideally, wouldn't it be great if you had information on what those claims payments were, or encounter data from the vendor? We recognize that you don't have that, and it varies across payers, it varies across carved out services. And so there are ways in which you can estimate that or peanut butter it out. And so if you go to the next slide, keep going one more forward. So the options here are, you could estimate a PMPM spending on whatever that service is for the population, and spread it out. You could risk adjust it. You don't have to risk adjust it. You could do just that straight peanut butter. You could take, you could remove the admin component. You could keep the admin component in, depending on what you know. So I think here in this case, there's flexibility for two reasons. One, we recognize we don't know all of the data that you have access to. We recognize that these dollars are booked differently on everyone's in everyone's sort of accounting practices, and you might not have access to some of this data. I think the message here is that there is a desire for you to make a reasonable estimate of a per member per month service category spend for any service that you carve out, So that way, when we look across the populations, this is really in particular for the commercial population. Although you may carve it out for other, I shouldn't say it's just for the commercial population, but we want to make sure that we're looking at apples and apples, and that not part of the population has no lab or part of the population has no pharmacy. So it's really trying to get everyone to have the dollars appropriately allocated, recognizing there are going to be some that are way above and some individual members that are way below, and that's okay for this particular purposes. Does this make sense? And Tracy or Anna, I don't mean to call on you guys, if you want to provide some input here into the work you've done in other states in terms of how you've made these estimates.
Yeah, this is Tracy from CVS Health. We carve out pharmacy only, and to do that, we worked with our actuarial folks who looked at some history and some spending for our fully insured members, and then we created an estimate per member per month to spread across the self-insured members that have pharmacy carve out.
Thanks, Tracy. Drew, do you have your hand up, or is it an old hand?
It's a new hand.
A new hand, go ahead.
So, well, you threw me for a loop with the risk adjustment component, and I had this impression that we'd be risk adjusting at a per person basis, not at a per person per category of service basis.
That's correct. I will say though that we, for some states, have asked the payers to provide us with a methodology by which they spread out a particular service that they carved out, and one decided to create a risk adjusted peanut butter spread, for lack of a better term. And so I just offer that as an option. It's not this is not a requirement. This is just a couple of different thoughts on how to do it.
Thanks.
So I think we've heard that it's going to be very helpful for the guidance to be explicit about where payers have flexibility in methods or how they're putting this together based on, again, as Megan said, the access to the data or how things are booked or any number of other considerations. This is one place where there would be flexibility for payers. I don't think we're going to try to say there's one reasonable estimate methodology that every payer has to include for all carved out services. I think we're saying we would like you to make a reasonable estimate. Your choice how you do that based on what makes the most sense for you, knowing what the intent is here, and knowing that we might have questions or ask for some additional information about how that was done, just to follow the thread of everything through.
Thanks, Sarah. Okay, so Sarah, at the outset of the call today, you mentioned that behavioral health services are going to be its own category. Is that right?
Talked about this last month, and we talked about pulling out behavioral health professionals, similar to calling out primary care providers. So behavioral health providers, not that there would be an overlapping, not mutually exclusive behavioral health services category that would pull in inpatient, outpatient, pharmacy. That was not the direction we're going in. This is just about behavioral health provider professional services.
Great. Okay. Thanks for that clarification. So we have an unsolved problem. And that is, what do you do when you have a behavioral health carve out? How do you actually peanut butter that PMPM across the different service categories, since this is not a cleanly defined set of services? So you'll have inpatient psychiatric care, you'll have pharmacy, inpatient psychiatric care would go into hospital inpatient, the pharmacy would obviously go into pharmacy. You're going to have professional spending on behavioral health professionals, psychologists, social workers, et cetera, that go into perhaps the other, now the behavioral health professional category. And so the question I think I have here is, what is the most logical approach to take for those of you with a behavioral health carve out? Do you have access to that data to understand what the PMPM spend is on hospital inpatient versus outpatient for behavioral health? Or do you only understand the capitation that you're paying to that vendor, that $100 PM, and you're not sure where it goes? We think that it would be good to provide some guidance here, again, with some flexibility about how you do this, but it came clear in conversations in other states that when there's a behavioral health carve out, how does it get proportionally allocated to the appropriate service categories? And that has become somewhat problematic. And so I'd like to just offer just an open discussion here about ideas that you might have. And it looks like Terry, you want to chime in and go first?
Sure. Yeah. Our ability to break out those individual buckets at this point is pretty limited, at least in the metro area. We don't anticipate that we'll have that problem forever. We are working on being able to have a better ability to split out the individual buckets, but at least as of right now, it would be really, really hard to do that.
Okay, that's helpful perspective. Thank you. Anybody else want to chime in?
Providence is one of the carriers that in at least the base period, our behavioral health services have been carved out. We do have the encounter data that does have what we believe to be the allowed amount. We could probably allocate it. It's work, right? I mean, you're asking, it's another set of analyses to do before we complete the template. If you add this on top of everything else, it starts to hurt. But it can be done. Is the ask that if you can do it, we have to do it?
I don't think we have a recommendation or an ask at this point. I think we're trying to understand the number of carriers that can do it or different approaches. What I've seen in data from other states is this other category, sort of the other claims, can get pretty big. And then you don't exactly know what's in it and it becomes difficult to analyze. That may be the answer. Drew, the answer of if you have it, do it, may be the answer. I think there's some openness here. And I think there's a desire to understand what you may all have access to and what you don't have access to.
Recognizing the lift that this would be if you have the data and can use it, and it does create an additional layer of analysis. Would you all prefer that we sort of give a hierarchy of recommendations, or especially for this initial data period, just leave it open-ended, any methodology that you would like, you just have to tell us what you did?
Can you just clarify the categories that you would like us to break this out if possible? Is it just inpatient, outpatient, professional, or other? Are those the choices?
Or behavioral health spend, or in general?
What you're talking about here, if it's just the PM, and you're saying, can you allocate it by categories? What are those categories? Is just those three: inpatient, outpatient, professional?
No, it's inpatient, outpatient, professional spending broken out by primary care, specialty, behavioral health, and other, long-term care,
residential,
pharmacy.
substance abuse.
No, we don't have that level of detail at this point. Wait, I'm sorry.
So residential services, that's facility based, but
that would probably go in long-term care, right? So this is actually a good conversation we haven't decided.
Care. Yeah, some of it's included in long-term care, and I think some of it might be included in inpatient as well. There's some bullets defining what's in what.
Probably some guidance on that would help. So this is Dean. Say the encounter data, we have the encounter data, and we theoretically could do this. Do you inflate or deflate the encounter data based on what you actually paid in capitation for certain the categories equally?
So right, because you don't know the exact dollar amounts that were paid. through that, right?
No, we do, but it doesn't match. Obviously, it's not going to match the capitation that you paid. So
I mean, so
you're going to either allocate less or more to a certain category based on the overall
I don't think
encounter
it's
data.
trying to reprice the encounter data. I think it's trying to use the encounter data to determine how the capitation payment should be proportionally allocated.
yes,
Right. Yeah, that's what I'm saying. So
yeah,
you have $100 in capitation and $110 in encounter data value. Do you equally decrement each one of these categories 10%?
no, I don't.
Or
No. So
$10?
you say of that 110, what percentage of that 110 went to pharmacy, and then you apply that percentage to the 100.
That's what I'm saying. So you
I think you're saying the
equally.
same thing.
Yeah, I think mathematically those are the same thing. It's just different approaches to weighting it.
Okay, so what I think I'm
certainly the categories would be helpful to have on what you're looking at.
Yep. So let me just recap what I heard. At least Care Oregon indicated that they can't do this at this moment because of the access they have to data, and that probably applies to a couple other payers. And then I heard that there are some payers with access to the data, but it would be another lift. At some point, maybe there's a prioritization of the lifts that you're being asked to do. And so I think that's something that we need to take back and determine internally. And then the last thing I think I heard was that no matter what is decided, a little bit more guidance around this, and also the flag to say, this is standardized. This is up to individual carriers. Terry, do you have a comment here?
Yeah, I decided to put my hand back up. I think the prioritization is really important. There is an administrative burden to be associated with this work, and I know it's not the intent to add a lot. So as much as we can build onto existing processes that we already have, I mean, that would be fantastic. But for new things, like if we do say, okay, we have to have this split out, for example, for behavioral health, if we could do that in a phase 2 with a timeline or something, it would give us something to work towards without having to, add staff immediately to try and make that big lift. Yeah.
Okay, we hear that for sure.
Can I ask, I totally hear that. And I like the idea of sort of phase 2. So this initial data submission and then future data submissions. If we said, do it one way, easiest way possible for this initial data submission, does it make more sense to you to just put all of the behavioral health carve out in the other category, knowing that makes that maybe a large category and we don't have full nuance? Or this fourth bullet about creating a new category that's specifically to put the behavioral health carve out in as just a lump sum? Preference between those two?
This is Terry again. My preference would be to have a behavioral health bucket. Yeah. It allows for analysis of the behavioral health spend, whereas otherwise you'd have some tough time trying to ferret that out.
This is Anne from United. I have a question. So are you planning on categorizing the non-carve out, the claims that in the commercial claims we already have behavioral included? So are you thinking that you're going to down the road have us bucket those separately as well?
That was exactly the question I was going to ask Anna. So the inverse is, if you don't have this carved out, how do you feel about creating a bucket that's behavioral health?
Well, we do that now for Massachusetts. I think you know that, Megan, last year they put in a new report. So I think what would help us would be the taxonomy codes if you guys provided that to us.
Right. And I think this is what we talked about a little bit last month about whether or not there should be a behavioral health service category as opposed to the behavioral health professional. And I thought we had leaned against doing that because it would muddy the waters for the other specific categories, but I think this is a new wrinkle, and I want us to think about this more a little bit internally. I do agree that if we want anything specifically documented in a certain way, we will provide the taxonomy.
Sarah, this is Tracy Cole.
Go ahead, Tracy.
I can't tell. Can you hear me? I can't tell if I'm muted or unmuted here.
I can hear you now.
Okay. I just wanted to mention with regard to taxonomy codes, we don't really have a lot of population for those. So I found that with the state of Connecticut and Delaware too, that we've needed to, if we do break out different categories, we need to use specialty codes. So just something to keep in mind that when you're providing guidance how to break them out, we would need some guidance if the taxonomy code is not available for the provider.
Got it. Thanks. Other comments on this, or should we move on to our next question? Okay, let's keep going. Michelle, can you move us to the next section, please? Oh, Megan, sorry, one more. We had one more for you.
That's okay. That's okay. So in April, we heard from a couple of payers, or maybe just one payer, that there is a vendor who manages performance incentive payments for a payer. And so we took this back, and I think, again, with that lens of focus, our feeling was include it in TME if those are the incentive dollars that that you're paying for whatever incentive program that you may have, even if it does include sort of an admin fee for that vendor to do it. If you, again, like I think with that other conversation, if you can separate out that admin portion from the incentive payments, please do so. If you can't, that's okay. Seem reasonable?
Yes.
Okay. All right, Sarah, now you can take it on to the next section.
Next question. So this is also something that came up in April, and we wanted to talk about how to handle pharmacy rebates that are passed back to employers. So self-insured conversation primarily. Next slide, please. So just to set the stage here, rebates are not allocated at the patient or provider level. They're applied in aggregate at the payer and market level. So our suggested approach here is that any rebates that are received by the payers would be reported in that aggregate level, regardless of whether or not the payer passed them back along to the employer or the purchaser. And we wanted to see what you thought about that proposed approach.
Sounds great.
Seems reasonable.
All right, sold. We're going to move on.
We need balloons, Sarah.
No, seriously though, any concerns about that? I'm going to take your silence as assent. Okay, cool. Zachary, Yishan, you're up.
All right, we're gonna go a little into some math here, but I think we'll be okay. They let me out of the basement to talk about some math. So let's talk about standard deviation and variance. Michelle, let's advance. Okay, so Sarah attached our draft methodology write-up. It's a very engaging read if you haven't read it yet. Warning, there's some formula there. It's kind of essentially how we're going to approach the statistical testing. In short, if we can, with 95% confidence, show that a carrier or large provider group exceeded the target, then then it's like, okay, well, yeah, they did exceed the target. So here's just a quick little graphic. The little dot is the actual percent growth. The little bands are the confidence intervals. As you can see for carrier A, the dot exceeded 3.4%, but given the confidence interval, touches the line and actually goes over the line, we can't say with confidence that they exceeded the target, but we can with carrier B, because maybe carrier B has a huge population, or their variance or standard deviation were relatively narrow, or whatever the case may be. And then only payers and provider orgs who exceed the target with statistical confidence will be held accountable. Here's a lot of math, but essentially, here's generally how we're going to approach it. The OHA team will conduct the confidence interval tests using the average PMPM cost as one factor, the number of member months to show how size, what size of the population you're working with. And then we also need either the standard deviation or the variance. Now these, we can calculate one from the other, right? Because one is the squared of the other, or the other is the square root of the other. But in order to analyze all your different rows of data and apply a confidence interval testing, we'll need some measurement of distribution within each row. So that's why we need the SD or the variance. So we're going to pool the variance together, and then we use that pool to drive the confidence interval test. We go into much more detail in the handout, but at a high level, that's kind of what we're working with. Let's go to the next slide. Okay, so what does it look like in the actual template? So we have a couple different options here. I don't have a preference, to be honest, so it's kind of whatever is easiest for you all. Option one is to collect the risk-adjusted standard deviation for each row of data for a given provider organization. So at the top here, we have line business code 2, provider organization is hospital system Z. You're going to include the provider org NPI, blah, 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 all that other stuff. And then a risk-adjusted standard deviation of 166.67. Or option 2 is to show the variance, which is the squared value of the above. So same thing, hospital system Z, but it's the variance, the risk-adjusted variance for that row. To my knowledge, pretty much all statistical programs that I've ever worked with have something that's pretty well kind of already built in to calculate the standard deviation or the variance of a given population. So kind of just depends on what folks' preferences are. Let's go to the next slide. I think we have one more.
I got proposed option 3.
Go ahead. What's option 3?
Well, so when you're talking about the preamble to option 3 is, if you're talking about either the standard deviation or the variance, I mean, there could be a lot of ways to do that. And maybe, like depending on if you're talking about the standard deviation over days, weeks, or months, or years. And so, the larger the time period, of course, the more variation you're going to have. So we would need a lot more definition, and it seems to me like that is asking for trouble. It might be that data, if you were to supply data by month instead of by year, then you could do any kind of calculation you wanted to see how much the claims costs are wobbling around. And you wouldn't need to collect either one of those from us.
Go ahead.
So this is Drew. Bill, not too thrilled about having to supply a row for every month for every attributed provider. But I had a question about in a similar line that Bill was headed on, which is what's the unit of observation to measure the standard deviation? Is it at the member level for the time period, or is it the member month level? In other words, Drew Tarab has 12 member months. Am I reporting out the standard deviation for every single member month across all the members, or at the member level across the year?
So I think it would be shooting from the hip. I think it would be at the member level. Now, there may be some noise there because a given member can be attributed to one entity for 6 months and in a different row for another 6 months. But given that these are all kind of after the fact, right? Because they're reporting for the previous calendar year and all actual paid amounts, either in claims or non-claims. In my mind, it's kind of the risk-adjusted members and the amounts that were paid for those members stratified by whatever entity they are attributed to and the distribution of that cohort.
So the unique members in that row, not the unique member months in that row.
Let me push back a little bit on that, because what you're trying to measure here is the performance of the provider. And so when you're calculating a provider's trend, you're going to say, did that provider, exceed the cost target or not? You don't care about the differences between individual members at that point. What you care about is, okay, you said that from this year to this year, the cost growth was 5%. But maybe if you looked across many years, you'd see sometimes it's 4 and sometimes it's 6. So, can you really say it's 5? I mean, you're talking that. I think that the level of aggregation here that you're looking for is not at the member, but it's at the level that you're trying to evaluate the cost growth. And so if you're trying to evaluate the cost growth for a provider, then it's the variance at the provider level over many years. And similarly, the same thing would apply for a plan. And that's why I'm saying, I think we already have to know all of this information by month, because members can be attributed to different providers at different times during the year. And, unless we're sitting there saying, a provider is going to get tagged with all of the cost for a member that they had on December 31st, regardless of how long that member was assigned to that provider during the year. My experience.
We are going to say that, just to be clear, that is how it works.
Say? Okay.
Yeah.
Well,
and I just wanted to be clear that I think this multiple years bill that you're bringing up is a little bit of a distraction. I think, like, mathematically, statistically, philosophically, that's probably accurate, but I think we are specifically charged with looking at the year-to-year change. And I think that's where we're coming into this member level, and it's just the change between one year and the next, not relative to change over multiple years.
Right. Yeah, maybe. I hear you, and I'm not. I think there's a misunderstanding going on here about this. It's definitely not. You are not interested in the variation between members. I just would promise you that. You don't care about that. You care about how accurate is your estimate of this provider had 6.3% trend this year. How sure are you that that trend at that provider is 6.3%? And that a standard deviation of cost by member is not going to help you with that.
Drew, before you jump in, let me just respond quickly to Bill. Conceptually, I think you're right, Bill. I mean, I can't imagine we're going to do kind of a deep dive into the variance or standard deviation of a given provider. We really only need it, as you say, for confidence interval testing and for pooling all of these rows together to then calculate the overall confidence interval for the market in that pair, for that pair.
I think we had Drew, then Dean, then Jared.
Sorry, I guess we have some divergent perspective. I do see the value in reporting out an interval in the base and the interval in the measurement period, and for each row. Which case, I have a hard time thinking about how it wouldn't be measured at the member level. The variance would be, because that's the source of the variance for that particular row. And I think for those who might be like I'm not sure, for at least the way we think of it, this is a test or a control for outlier humans, outlier members who might push up or push down the base period or experience period value. We're not ignoring that. We're just saying that just widens the confidence interval so that we can't, so that the OHA wouldn't say with confidence or statistical confidence that this is above the growth target.
Yeah, that's exactly right. Yeah, and then as I think about kind of is this at the member month level or member level? I mean, to me, it comes down to the risk adjustment. I'm thinking is at the member level, and so it kind of has to be the spread of those costs also have to be at the member level. That's just what makes sense in my mind.
Got a few more hands up. I think Dean, Jared, and Tracy.
Yeah, this is Dean. I'm quite confused here on your example. So what I thought I understood is that you were wanting to do standard deviation or variance on the plan's rate of growth, but here you're getting down to the individual system or hospital system or large provider group cause to creating that rate of growth and then somehow holding that hospital or provider accountable? Is that what I'm hearing here?
Yeah, that's right. So let's say hospital system Z here, just to like pull the thread here on this example. Let's say 5 payers contract with hospital system Z, which is not completely impossible. That's probably even likely. So given that each payer is going to submit their own average risk adjusted costs and some kind of number for distribution, either the standard deviation or the variance, we then can pool the rows that for hospital system Z from the 5 different payers across to get a more holistic view of, okay, what are the costs, what are the payments going to hospital system Z? We can use, pooled variance formula to figure that out and apply that same confidence interval testing. Just as we can look at the different rows within a given payer's template and pool all this spending together and say, oh, here's one payer, let's apply confidence interval testing for all that payer's rows of data. So there's kind of multi-dimensional going on.
The only providers that you would do this to would actually have member months. So not say they're just a fee-for-service provider.
We'd only do it to these entities that kind of have attributed lives or have some kind of members. Either you're assigning them or they've established as primary care homes or whatever the case may be. Yeah, we wouldn't be able to do it to those entities that are, super. I was going to say super specialists, but every payer I think will have kind of an other row where it's like lives that just aren't attributed. We wouldn't be able to do anything with that for this pooling mechanism.
Goodness.
Jared.
Yeah, thanks, Sarah. I have just 2 questions or maybe comments. One is, as I've looked at variance across blocks of members, it's pretty hard to get a full view of the underlying potential variation in medical spend when you subdivide it, just as you look at the upper tail of costs and particularly catastrophic members. So just wondering if you had considered maybe having a blended variance for all provider systems. I think there's probably a difference for for the different lines of business, especially Medicare versus commercial. But I just worry a little bit as you're looking at smaller populations that you don't get the full impact of medical cost variations. So that's my first question. And then the other one is the examples in the attached document highlight another concern I have on the measurement. When you talk about pooling and comparing a cost year over year, it doesn't seem to reflect or account for growth in a particular area. You know, if hospital system Z, for example, is 20% higher than the other group, and you just happen to have an expansion, or you pick up a large group that's serviced by hospital system Z, you appear as a carrier to exceed the cost growth, when in reality, you may not if you look at each system individually. So just wondering if that was considered.
Yeah, so to your first point, I think we can definitely explore having the payers submit overall variance or standard deviation. I think that would probably be fine. We should talk about it a little more. My initial thought was, well, let's kind of save you the burden of having to do another calculation, and we would just use pooling to calculate it. But I think we can make that open for a discussion. For your second point, it is possible that for payer A paying hospital system Z, hospital system Z looks like it grew by a whole lot, but payer B's payments to hospital system Z didn't really grow at all, or maybe even contracted. I think that is possible. And so that's why it's important to kind of take these take these already aggregated rows, but pool them even further. So we have more kind of statistical confidence about what's going on, and then figure out like who to hold who accountable, kind of thing.
So,
and I also want to add, just for context, the statistical testing step is also not the final step in this process. So the data come in, the pooling, the testing all happens. We have those results. That is the opening for the conversation with the payers and the providers. Here's what we see. And the example that you gave, Jared, is exactly the kind of thing that we would hope to come out contextually. It's not something that we're hoping to see directly. You know, we're not going to be able to see every single contextual factor in the data, and we will have to have those conversations to unpack some of these things.
Yeah, and just to be clear, my example was not that we're paying the system more year over year. You could have a 2% growth for every provider, which is below the target, right? But if you just have more members going to the higher cost provider due to group acquisition or whatever, you exceed the target. And that's a very easy situation to address mathematically in the formulas. You just have to fix either the performance year distribution or the base year distribution. And so I guess that would be my recommendation, to adjust it so that it doesn't show something that's misleading.
I see what you're saying. Yep. Yeah, we can explore kind of different ways to analyze it at that level to account for membership attribution changes. I'd have to think about how to do that uniformly and consistently across the board, but worth looking into.
I think we had Tracy and then Clara.
Actually, I just wanted to say that Connecticut had instituted a variance calculation that we're working on. But whatever decision is made, we went back to request a spreadsheet that shows the calculation examples. That was very helpful for us, and it wasn't something that we got with the initial requirement. So
Sarah and Zachary have it in their inbox now.
Thanks for that. Yeah, whichever kind of route we go, or if we go to some third option that is mutually agreeable, yeah, we would likely publish some examples, some Excel spreadsheets that kind of walk folks through at least how we're envisioning it. And like I mentioned, I mean, a lot of statistical programs can do that, but you still have to point to the right parameters. So I don't want to belittle the amount of work that it would require to do either of these. It's still an analyst kind of crunching on this and figuring out how to do it.
And when we're thinking about priorities for the lift, I think this is going to be a priority. This was an implementation committee decision that really provides some foundation for accountability. And I think there's a whole conversation we could have about that and why, but I think we really need to make sure that we have this. And I think making sure that we have this and whatever the lift needs to be for having the ability to conduct the testing to then support the accountability conversations will be a priority. Clara, then Drew.
Yeah, I think I'm just agreeing here with Jared's first point, that I wanted to understand that the variance is measured for an average Oregonian, not your average provider A's patient. Because I mean, I'm thinking about some extreme example where a provider gets 2 members and they both have transplants. You're going to observe that in the universe of that provider, they have very low variance, but in the randomness of what goes where, that provider happened to get very outlier cases. And I think the variance needs to be considered globally, not line by line here. Whether you actually want to collect it line by line, maybe that's fine, but I don't think that 166 should ever be used to judge that specific provider. I think it needs to be considered globally. Hopefully that made some sense.
Yeah, that does make sense, and I think that aligns with how we're envisioning it, because there would never be the case where we would assess. At least I don't think so. I'd have to think about this. I don't imagine there'd be a case in which we're assessing hospital system Z for one payer's single row. I
do think there's a case if they are the only payer in the state that has patients that are members that are with hospital system Z. It is possible that there could be.
I guess it's possible, yeah.
In between a payer and a provider organization, and we would only be using that one payer's row. I don't think that's likely, but I think it's possible.
I guess I didn't mean to make the case cross. Say a hospital gets all the transplant cases and the other hospital in the town doesn't. They could look consistently expensive with low variance in their own world of transplant patients, but they should be given the acknowledgement that statistically they just randomly got the 2 transplant patients in the state. And so I think it goes beyond just the payer level, but even from the provider's perspective, I don't even know if that's big enough to think about variance within the provider. I think it needs to be about variance among Oregonians seeking healthcare.
Yeah, I think it's a fair point. I mean, part of the confidence interval test includes the number of member months. And so if we are talking about a provider with literally, 10 people attributed to it, and all 10 just had crazy high costs that didn't really vary so much, that I don't think they wouldn't pass the confidence interval test, if you will, because they have such small member months. So part of this might be maybe some overly reliance on the law of large numbers, right? That hoping with a large enough cohort, you're going to get variation. And if you have 1,000 members for 12,000 member months or whatever, chances are you're not going to have all of those people who are really high cost and low variance. So, part of this is kind of relying on the gods of statistics here. But it's a fair point, and we should think about and make sure that we're not relying on kind of small populations to drive accountability.
I'll just throw out, sorry to
no, please.
Point, but healthcare has such massive tail claims. It concerns me that the law of large numbers, you need much, much larger numbers than you'd expect, that even if you do have, say, all the hospital patients and it seems big enough, it might not be big enough to absorb a couple of $5 million cases.
Yeah, fair point. Yeah, we're not talking about normal distributions here. Yeah.
Drew?
I had a couple of questions that I think partly address some of the topics, or they're related to what Jared and I think it was Clara that was just asking. One is the standard, however we approach the standard deviation, is it fair to assume that it's the sum of all the costs divided by the risk adjuster value, normalized risk adjustment value? So in other words, when you say risk adjusted standard deviation, it's the sum of the member's cost for that row after applying risk adjustment, right? Is that accurate?
The way I think about it, Drew, sorry, is because you're probably doing risk adjustment on the individual level.
Yes.
So it's the spread, it's the distribution those individuals post adjustment.
Thank you.
Yeah.
Okay. And then the next question is tangentially related. I don't remember if it was last tag or if it was some side discussion about potentially putting a cap on claim value, where claim value over X threshold, whatever to be agreed upon, would be trunked. Is this standard deviation? Would this standard deviation calc be net of truncation if we did apply truncation?
So I think truncation, good question. I think truncation is probably a whole nother tag meeting in and of itself. And how that truncation does or does not interact with pretty much all the decisions we've made thus far, I think warrants its own full conversation. That's me wiggling out of answering it because I don't know. It really depends on how that truncation works and if we're going to do it at all. So I think we should shelve it for now and probably come back to it at some point.
And I want to just recognize the history of these conversations. So we originally started with no truncation, everything's in. And so now we're worried about outliers. And so now we have this whole confidence testing approach so that we can control for some of that and not just be holding payers and providers accountable for things that are beyond their control. I think now that we're introducing truncation back into the conversation, that is changing this whole flow, but just to recognize that we didn't talk about those two simultaneously and make the decision to have both solutions. We started with one and now we're talking about the other, and we'll have to go back and look at all of the decisions, as Zachary said. Bill, looks like you have one more comment, and then I want to wrap this conversation up.
Yeah, I just have two questions. Question number one, do you intend to assign members to specialists, hospitals, labs, etc.? Because I see in these tables, you've got hospital system Z in there. And I'm just not sure how it even makes sense to do this at the member level for a hospital. And then
yeah, so, go ahead, and then I'll jump in.
No, you answer that one first.
So a couple points of clarification. So we're not assigning or attributing anyone. That's going to be on your side. The hospital system Z here is, in our imaginary example, is some kind of massive system that has primary care, outpatient care. They just have a lot going on, so they do have members attributed to them. This wouldn't only be kind of inpatient services. But again, at your discretion in a way, because the attribution or assignment is at that payer level.
Well, that doesn't help because I'm just whether we do it or you do it, I'm just curious if the intent is to assign a member to a hospital.
The intent is to have primary care-based attribution. And so for the larger hospital systems that do have associated primary services, that will all get rolled up into the overarching line hospital system X. But if there's a hospital that does not have a primary care hook to it, then that hospital or that hospital system would not show up.
Right.
That makes a huge assumption that the amount of primary care provided by that hospital system corresponds in some way to the amount of hospital or specialist care provided by that system, doesn't it?
It's corollary to, let's look at row 3 here, Main Street Provider Group. So there are 1,000 individuals assigned to Main Street Provider Group, and it's a big primary care clinic or something. All of those individuals' costs would be captured by that row, even if those costs are encountered at a local hospital. So it's so by kind of taking people and kind of stratifying them by where they're attributed and bucketing all those costs in that one row, we're dividing up the cohort in kind of a primary care like rubric.
So I guess what you're saying is you're only planning on doing this for primary care. you're not going to be calculating a standard deviation for hospital care, except to say that that hospital care is going to be assigned to the primary care practice managing the member.
Yeah, that's right.
Dollars follow the person, and we're only doing this for those attributed members for these rows. But okay. I want to cut us here because we're just about out of time, and I want to talk about next steps real quick. So I know, Bill, you said you had multiple questions. So if you want to email, that would be great. So we're going to skip the risk adjustment conversation. We'll pick that up next time. There are some updates in the slides that are available for you. But in terms of next steps for the submission template and specifications, our goal is to get the data submission template and specifications finalized and out the door to you all by the end of June. We know that earlier is better, obviously, but there's still lots of things to work through. I do not want to wait until the end of June to have our next tag meeting to work through some of these things, especially the things that we said today we want to think about some more and come back. I would like to propose scheduling a second June tag meeting so that we can come back and continue some of these conversations and still meet our goal to finalize the specs by the end of the month. I do intend to push out an updated specifications document and template to you all probably early next week and have that circulating for feedback. Again, I know there'll be some questions, and we've been trying to reflect the tag discussions and decisions in that document as we go, but there are definitely still some outstanding questions. So we'll push that out to you for feedback. Please send us questions over email. Are folks willing to join a second tag meeting in June?
Yes.
Yep.
Great.
Yes.
Thank you.
Sure.
I really appreciate all of this feedback. It's been incredibly helpful. I think especially since not all of you have necessarily dug fully into the statistical testing methodology. If you have more questions about that, we really would love all of your peer review on that. Please send us feedback, questions, comments, third options, all of that would be super welcome. And I will start working on getting a second tag meeting on the calendar. Any other questions or comments people want to make today?
I'll just, if I may, just say what kind of to wrap up the last conversation. So other states aren't doing this, to my knowledge, at least not to the extent we are. And the reason we are is because our implementation committee wanted to put in some kind of safeguards to say, well, we only want those entities that are kind of large enough and statistically we have some confidence there that if they did exceed the cost growth target, it wasn't because of just random noise. I mean, what would they wanted to try to rein it in a bit with some level of statistical analysis. So that's what put us on this path. And I think we'll figure it out collectively. But unfortunately, we don't have other states to look to give us the answers.
No, but other states will be looking to Oregon. And so if you're participating in other states, know that this may actually be spread throughout the other states too.
So no pressure. That's all I got.
Any final comments? There is some content in the slides that we did not cover today. If people have questions about that, want to read anything over, just let us know. Happy to answer that over email. We have a little bit of a preview about the risk adjustment conversation we want to have and talk about some of the options. I think if we're going to schedule a second tag meeting, we can make some space on the agenda for that as well. And I think one thing that I want to go think about some more, and I guess I'd ask all of you to think about some more too, is with our goal of finalizing the specifications and the data submission template by the end of June to cover the initial data submission, where do we draw the line on some of these things and say, this is phase one, we're going to do it this way, here's the initial submission, and then think about what modifications we might make for future data submissions as we continue to have some of these conversations, whether it's about risk adjustment or truncating outliers or something else. So I think I want to start creating some more distinction between we've made a decision for the initial data submission and then that's locked in and things that we're still iterating on. All right, our next meeting, well, officially our next meeting is at the end of June. I will schedule a meeting before that, so I will talk to you all soon. And again, please send us any comments or questions over email. Your feedback is super helpful, and we really value all of your engagement in this group. Thanks, everyone. Happy Wednesday.
Thank you.
Thank you
So much, everyone. Bye.